Welcome to another International Dermatology Foundation Educational Series Webinar. This evening, we're going to have a joint approach to psoriatic disease management with Bimzelx for your patients with psoriasis and psoriatic arthritis. Our moderator this evening is Dr. Leon Kircik, who's the Medical Director of the International Dermatology Foundation, Clinical Professor of Dermatology at the Icahn School of Medicine at Mount Sinai, New York, and Adjunct Clinical Professor of Dermatology, Indiana University Medical Center in Indianapolis, and Medical Director of Physician Skincare, DermResearch, and Skin Sciences in Louisville, Kentucky. Our speakers this evening is Dr. April Armstrong, who's Professor and Chief of Dermatology at UCLA Health, Professor of Dermatology, Associate Dean for Clinical Research, and Director of Clinical Research Support at Southern California Clinical and Translational Science Institute. Also, we have with us this evening Dr. Gordon Lamb, who's board-certified rheumatologist at Atrium Health Carolinas Medical Center in Charlotte, Carolina. We'd like to thank our supporter, UCB, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the information will be displayed. If you're having technical issues, please submit your question in the question chat pane on the right-hand side of your screen, and we will respond to you. At the end of this webinar, a survey will pop up in your browser and also will be sent to you 1 to 2 days later. We greatly appreciate it if you could fill it in and send it back to us. And within 1 to 2 days of the webinar, a certificate of attendance will be sent to you. If you'd like to submit your questions, again, please submit your questions in the question chat pane on the right-hand side of your screen. And now, without further ado, I will pass the floor virtually to Dr. Kircik.
Good evening, everyone, and thank you, Roxanne. Welcome to it's my first International Dermatology Foundation webinar tonight of the 2026. We had one last week, but I couldn't participate. I was overseas. So just to introduce briefly, International Dermatology Foundation, our principal mission is to raise awareness and improve dermatology care all over the world, especially in underserved areas, through education. And really, since the pandemic, we've been all over the world, including North America, Canada, but also in South America, Southeast Asia, as well as Europe. As you can see from some of our previous invitation and previous programs, we have included several different topics and several different pharmaceutical companies that they have supported us. So now, before further we go without any further ado, I'd like to introduce our speakers, but also I urge you to follow us on social media, on Instagram, on Facebook, as well as LinkedIn. Tonight, we have a very special program, actually. We have 2 speakers. The first one is, I don't think she needs any introduction, a good friend of mine, Dr. April Armstrong, who is a professor and chief of dermatology at UCLA Health. But also, we have a bonus speaker tonight, Dr. Gordon Lamb from Atrium Health Carolinas at Medical Center in Charlotte, who is a board-certified dermatologist, and we're gonna get a great perspective on Bimzelx for your patient, both from the psoriasis perspective and from the psoriatic arthritis perspective, from the rheumatologist perspective. I think most of us in dermatology have always this concern and fear how to handle psoriatic arthritis, right, April? How to deal with the joints. So we're gonna have a great program tonight. We're gonna get not only derm, but also the rheumatology perspective. Thank you and welcome, Dr. Lamb, and April, take it over.
Great. Thank you so much, Dr. Kircik. And it is such a pleasure to be here with Dr. Lamb, our rheumatology colleague here and expert, and really a true joint, no pun intended, program here. So we're very, very excited to talk about psoriasis and psoriatic arthritis, and especially with this combined approach towards psoriatic disease management. And we're going to go forward with the slide deck. All right. So when we're thinking about our joint disease approach and really think of our patients comprehensively, one of the things that we're going to focus on specifically is looking at Bimzelx, which is the first and only approved IL-17A and IL-17F inhibitor. So today we are going to discuss its efficacy not only in skin, but also in the joint, as well as a safety profile, and look forward to really a great discussion with Dr. Lamb about the potentials of Bimzelx in helping our patients with psoriatic disease. And here are the disclosures that this is a promotion program sponsored by UCB, and all the contents have been developed according to the FDA regulations. And with that, I'm going to turn the floor to Dr. Lamb.
Thanks, Dr. Armstrong. And also, I wanted to thank all of you for joining us tonight. I know that it's the start of a new year. It's the end of probably a very busy day. So thank you all for joining us. I really hope that the next 45 minutes or so will be a really fun and interesting and hopefully helpful discussion. And I have to say, it's a true honor to be presenting with Dr. Armstrong again. You all know her work. I've worked with her before, and it's such a pleasure to share the stage with her. So let me start by saying that in rheumatology, psoriatic arthritis is one of the more complex heterogeneous diseases. I mean, not only is there skin involvement, the psoriasis, and inflammatory joint pain, but there's also axial involvement. There's enthesitis, which is inflammation of tendons and ligaments into the insertion site of bone. There's dactylitis, which is swollen digits, and that's reflective of a tenosynovitis and a synovitis as well. There can also be other comorbidities. So for example, ocular inflammation like uveitis. There can be depression, metabolic syndromes, and non-alcoholic fatty liver disease, which the new term, according to one of my GI colleagues, is metabolic dysfunction associated steatotic liver disease, or MASDO. So it's a very comprehensive and heterogeneous disease. Oftentimes patients, because they have so many different manifestations, may kind of ping pong to all these different providers. They may see an orthopedic surgeon because of their sprained ankle, which is actually enthesitis. They could see an ophthalmologist for eye inflammation. Hey Roxanne, I think, yeah, here we go. They may see a chiropractor because of lower back pain. And it isn't until they actually see a dermatologist or a rheumatologist where we're able to make a unifying diagnosis, that is psoriasis, psoriatic arthritis, invoke Occam's razor, and then get them on the right treatment. I often liken psoriatic arthritis patients to the old parable of the blind men touching different parts of an elephant, and each is touching one specific part, and they think they're touching completely disparate things, when in fact it's all the same elephant. And in much the same way, when a psoriatic arthritis patient sees different providers, they may just focus on their one area of specialty and kind of miss the whole picture. So it's really important that we at least get the two most important specialists, at least in my mind, dermatology and rheumatology, together, since we often kind of take the lead in managing these patients. But as much as psoriatic arthritis is complex and heterogeneous, from a provider's perspective, from the patient's perspective, it's very multifaceted and can impact patients' lives as well. Patients not only have pain, but the root cause of the pain is the systemic inflammation, and that can lead to structural damage, joint erosions, which can then lead to physical disability and dysfunction. That can lead to mental health issues like depression. It can lead to reduced quality of life. And then the underlying systemic inflammation can cause cardiometabolic disorders as well. So we can kind of see that it has the spider web effect, where it can start to affect all aspects of the patient's life. And then for patients, a multidisciplinary collaboration is really key. It can lead to earlier diagnosis and treatment initiation. And in fact, some of the most recent data show that the average diagnostic delay for a patient with psoriatic arthritis, at least, can be up to 3 years. But if we collaborate with dermatologists as rheumatologists and other specialists, it can lead to earlier diagnosis, earlier treatment initiation. That can then lead to improvement in clinical response, preservation of function and quality of life, but most importantly, improvements to the patient satisfaction. I always tell the patients that my goal for them on day one is for them to lead a completely normal rest of their life. That's sort of my colloquialism of achieving remission. And in point of fact, GRAPPA, which is the Group for Research and Assessment of Psoriasis and Psoriatic Arthritis, and EULAR, which is the European League Against Rheumatism, that's sort of like the European equivalent of the American College of Rheumatology, or ACR, really recommend the multidisciplinary collaboration, and that's essential to diagnosing and managing patients with psoriatic arthritis and other psoriatic manifestations. Okay, so let's see, next slide. Okay, here we go. So April, that's kind of the rheumatologist perspective of psoriatic arthritis, but let me get your thoughts and your perspective from a dermatologist's perspective.
Yes, absolutely. And I think probably for the last 2 decades or so, we've been stressing the importance of really trying to identify patients that may be suitable for referral to rheumatology for further assessment for psoriatic arthritis. And as we know that many of these patients, they will present with skin signs and symptoms prior to their joint signs and symptoms. So I think as dermatologists and along with all my dermatology colleagues, one of the things that we've been talking about for a while in our field is how do we identify these people well, or how do we at least identify patients who may be more likely to be at risk for having psoriatic arthritis to refer to rheumatology. When I think about derms and how oftentimes the number of dermatologists in many parts of the world are few, equally that can be said about rheumatology, and if not, in some parts of the world we have even fewer rheumatologists that's needed to take care of our patients with psoriatic arthritis. So I think how do we really think about identifying correctly the patients that we want to refer, and in many instances, in certain settings, we may have to manage both psoriasis and psoriatic arthritis concurrently. And what we have really relied on is a lot of the epidemiologic data, for example, showing about 1 in 3 patients with psoriasis, if untreated, will ultimately develop psoriatic arthritis. And that's actually quite a large number when we think about the proportion of patients of psoriasis that we see and how many of them may potentially have the likelihood of developing PSA. I know that there has been a number of different screening tools that has been developed. I will say that in my conversations with my rheumatology colleagues, especially from GRAPPA, they have very much relied on the identification of inflammatory joint disease as really one of the key findings, which we're hoping to learn more from you, Dr. Lam, about that. You know, I'm always interested in understanding if there's one single question that you can ask a rheumatologist, what would it be? And hopefully we'll have some time to discuss that. But I would say derms are definitely very much heightened to the presence, the increased proportion of patients with PSA in the psoriasis population. And our main interest is how can we find the appropriate patients that we can either manage them ourselves if we were in the resource setting where the patients can't get to a rheumatologist quickly, or how can we identify those with the most high likelihood of having or developing PSA that we can get our rheumatology colleagues input. And speaking of screening tests, PEST is one of them that's been validated and used in a number of different settings. And with that, I'm hoping to have you, Dr. Lam, walk us through this, but also comment on any other things that you would like in terms of identification of PSA patients.
Yeah, so the PEST questionnaire is really simple. It's just 5 questions that you can ask your patient with psoriasis as a screen for psoriatic arthritis. And the 5 questions are simply, have you ever had a swollen joint or joints? Has a doctor ever told you that you have arthritis? Do your fingernails or toenails have holes or pits? That's sort of identifying the nail dystrophy associated with psoriasis. Have you ever had pain in your heel? And that's sort of identifying the Achilles tendon enthesitis, which is the most common kind of enthesitis. And then lastly, have you ever had a finger or toe that was completely swollen and painful for no apparent reason? And it's simply yes or no. And if they have 3 or more, then that indicates likely psoriatic arthritis. This is very helpful. It's very quick. It's very easy. Patients, you can give this questionnaire to patients and they can fill it out as they're waiting in their waiting room. But I'll make it even easier for you. And this is what I tell all of my dermatology friends and colleagues. Just simply ask your patients with psoriasis, do you have joint pain? And if the answer is yes, that absolutely warrants a referral to a rheumatologist. And the reason why is because There are over 100 different types of arthritis. Now, the majority of arthritis is osteoarthritis. That's degenerative arthritis. Wear and tear arthritis comes with age. We all will get it if we live long enough. However, the small subset of inflammatory arthritis really needs to be discerned, and there could be lots of different types of inflammatory arthritis. And I'll get to some of the characteristics in just a second. But even if they don't necessarily have psoriatic arthritis associated with psoriasis, they could have concomitant osteoarthritis with the psoriasis, gout. So gout is found at a higher incidence and prevalence within psoriasis because of the increased cell turnover leading to increased uric acid and gout. And then the characteristics are basically these questions, but to discern degenerative arthritis versus inflammatory arthritis, there are some key questions that we rheumatologists use. So one, if asked if the joints are not only swollen, but red and warm to touch, that indicates inflammation. If the symptoms are worse in the mornings, as opposed to worse in the evenings. In inflammatory arthritis, symptoms are worse in the mornings, they get better throughout the day. With degenerative arthritis, it's the opposite because after using the joints all day, they get worse. If the joints get better with rest, get better with movement as opposed to rest, with inflammatory arthritis, the joints get better with movement, whereas with degenerative arthritis, they get better with rest. And then also the age, so inflammatory arthritis typically occurs in younger patients, whereas degenerative arthritis occurs in older patients. And then duration of symptoms. So usually inflammatory arthritis may present acutely or subacutely. Degenerative arthritis kind of comes on insidiously over time. So these are some of the PEST questionnaires, but again, what may be easier is just to ask patients, do you have joint pain? And if they do have joint pain, then, so actually, hey Roxanne, not too sure if that's your screen. Yeah, there you go. And then if you could just advance to the next slide, please. Then to absolutely move on ahead. And then from a patient's perspective of psoriasis though, Dr. Armstrong, how do patients with psoriasis usually view their disease and level of disease control?
Yeah, so I think Dr. Lam, you already gave some really excellent pointers, really distinguishing degenerative versus the inflammatory arthritis, and I really like those pointers that you gave. In terms of disease control from a skin perspective, I shall say that the field, we've been very lucky in terms of having a number of different therapies these days available to our patients with psoriasis. So over time, what we see is that the patient expectation and also the clinician expectation have evolved over time, such that, for example, the patients now, they really expect a pretty rapid response, and many of them also having had some systemic therapies before, also understood what are the possibility of our therapeutics can do. So for example, 90% of our patients now place a really high importance on how rapid a response may be, and not just for, let's say, occasions where, such as weddings, but just in regular daily life, they wanted to see that benefit immediately. And in addition to that, they expect a very deep level of a response. So they're really looking at complete skin clearance as something that they would really want to achieve. So when I think about the degree and the level of disease control, we are really up the ante as we have come so far. And I think we see that in our patient expectations. We see that now. I think both you and I have had the pleasure of really taking care of different generations of patients. And it's really interesting seeing them, different generations coming into our clinic and how their expectations have evolved. And I would say overall, high bar is really the theme, at least, from the psoriasis end. What about you? Yeah.
Well, I think dermatology has really led the way, and you guys have set an aspirational goal that rheumatology is really striving to attain as well. In rheumatology, a 50% improvement is considered a benchmark. That's considered great. So that's an ACR 50. So ACR is American College of Rheumatology, 50% improvement. The MDA is a minimal disease activity, and that's a measure of low disease activity that we use in rheumatology. It's kind of a composite measure of several different aspects, domains like tender joints, swollen joints, psoriasis area, pain scores, physician global assessment, disability, and then enthesitis. And if they achieve a certain level, 5 out of 7 of these domains, we consider that a win. However, what we need to do is up the ante, like in dermatology, and really try to get a 90 or 100% improvement, complete remission. And the reason is because even in low disease activity states, so where we would be complacent and happy with, there can still be a significant burden to patients. Patients can continue to have pain, fatigue, sleep disturbances, impaired physical functioning. And actually about 25% of patients who have more than 4 joints affected can't even bend down to pick up clothes on the floor or tie their shoes. So that really significantly affects activities of daily living. And in fact, so much so that GRAPPA recommends that new treatment options really try to attain the lowest possible level of disease activity to improve quality of life. And quality of life is very individual and independent for each patient. So this really speaks to the aspect of personalized medicine. To do that, we really need to discuss proactively with patients what their disease is, how it impacts activities of daily life, and then what their independent treatment goals are. And then, so Dr. Armstrong, one of the things that we're going to get back to, I'm going to circle back to this, is how you discuss that with your patients. But before I do, let me just let everyone know who's online. So a lot of the research that we're citing is actually Dr. Armstrong's research. A lot of the things we're quoting are her reports. And that's one of the reasons why she's actually such a superstar, not only in dermatology, but in rheumatology as well. We quote her data all the time, and a lot of these are there. So this would be a good segue to discuss Bimzelx, which is the first and only approved biologic to selectively target IL-17A and IL-17F in plaque psoriasis and psoriatic arthritis. And it's important to know that Bimzelx is not simply a me-too IL-17 inhibitor. It's different because it has a different mechanism of action. To understand that, it helps to understand the mechanism of disease, and this is actually where Dr. Armstrong is one of her fortes as well.
Great. Thank you, Dr. Lamb. So we are, I'm really excited to talk about the science, and I think there has been such elegant science development in this area that have contributed to our understanding of the disease process. And later on, I know Dr. Lamb is going to talk about specifically of where Bimzelx act in this particular cascade. So when we think about key drivers of chronic inflammation, and especially as it relates to psoriasis, for example, the world that we live in as derms, we know that IL-17A as well as IL-17F are really some of the key drivers. And I think of A and F as really siblings. They're brothers or sisters, however you may think about them. They share about 50% homology. And then they also exist as dimers. So for example, as you can see here, the IL-17A exists in the AA dimer, or it can exist as a IL-17A with an IL-17F heterodimer, or it can exist as the IL-17FF homodimer. And these cytokines then can bind to the IL-17 receptor and then downstream lead to a number of activation of inflammatory additional cytokines downstream from where they are, and therefore signaling, for example, to the keratinocytes to proliferate, to turn over much faster, and then result in the clinical manifestations that we see. Two key messages to kind of take away from this is that number one, while we understand IL-17A is thought to have a greater potency, what we notice as a field is that IL-17F is actually more abundant. So the levels of IL-17F is more abundant in the, not only in the lesional skin, but also in the joint spaces as well for patients with psoriatic disease, and also in the serum in patients with psoriasis and psoriatic arthritis, and a number of other conditions as well. So this is important to note that IL-17F, just by the population of themselves, they exist in greater quantities in the target tissue as well as in the serum. If we take a look at the right-hand side, what you'll also see is that the production of IL-17A and F is notable as well. Some of the production of IL-17A and F are what we consider IL-23 dependent, and that is IL-23 activation of a number of different cells lead to the elaboration of IL-17A and F. However, there are also IL-23 independent pathways for the production of IL-17A and F. And why that's relevant is that we are comprehensively addressing, for example, IL-17A as well as IL-17F elevation with a molecule, Bimzelx here, that is regardless of how IL-17A and F is produced, whether it's IL-23 dependent or whether it's IL-23 independent.
So I always thought that understanding immunology is key to understanding disease. And actually, I'll be completely honest with you, when I was in medical school, I hated immunology. I used to fall asleep in the lectures. But then it wasn't until I started seeing patients and I realized that by understanding the immunology, you can understand the disease. And once you understand the disease, you can best treat patients. So as Dr. Armstrong mentioned, IL-17A and F are produced by the immune system, but it's produced by both the adaptive and the innate immune system. And that can lead to IL-23 dependent and independent pathways of IL-17. So, so let's say in a certain situation, whether there is increased biomechanical stress in a joint, or there's trauma in the skin, sort of the Kepner phenomenon, then cells of the myeloid lineage, that's our monocytes, macrophages, dendritic cells, Kupffer cells, they can increase IL-23 production. That can then stimulate adaptive lymphocytes like Th17 cells to produce IL-17A and F. But there's another pathway that's independent of IL-23, and this is mediated by other cytokines like IL-12 and IL-18 that can activate sentinel cells of the innate immune system. And these sentinel cells are things like mucosal-associated variant T cells, invariant natural killer cells, gamma delta T cells, and the group 3 innate lymphocytes. And these can then also produce IL-17A and F, which can then lead to disease. And the disease that we see are examples shown on the far right: plaque psoriasis, dactylitis, enthesitis, hidradenitis suppurativa. And interestingly, that's one of the reasons why IL-17 can have such a diverse manifestations because of its really complex and heterogeneous effect in the immune system. By understanding the immunology, we can understand the disease and we can better treat them. So how does that then translate to Bimzelx? So Bimzelx is a monoclonal antibody that binds both IL-17AA homodimers, FF homodimers, and AF heterodimers. And in doing so, provides more suppression of inflammation versus just targeting IL-17A alone. It leads to a broader and deeper inhibition of IL-17. So I like to think in terms of analogies, I think very simply in that sense. And the analogy that comes to mind is, you know how you have a sink and the sink has a spigot and it's spouting out water, and you have two of the faucets controls, and one is the hot water, the other is cold water. Well, you can kind of think of each of those faucets as regulators of IL-17A and F. And then Bimzelx can turn off both A and F. And doing so, you get a broader and deeper inhibition. As Dr. Armstrong mentioned, A is more potent, it's also found more prevalently early in disease, but F is more prevalent and it's found later in disease. So by targeting both A and F, hopefully we'll get a broader and deeper inhibition of IL-17. But the next question is, well, how does that relate to real world experience? So Dr. Armstrong, let me turn it back over to you and then we can start going over the clinical trials.
Yes, and I love that analogy of the sink, the hot water, and then indeed the cold water, and think about that and how both of those spigots can contribute to the inflammation. So here we're going to dive into the next section of our talk, which look over the clinical trial data as well as some of the real world data. And before we start that, I just want to talk about really the extent of the experience that we have with Bimzelx in terms of the worldwide experience, as you can see here. And this number is constantly increasing. Over 70,000 patients have been treated with Bimzelx worldwide. And in addition to psoriasis and psoriatic arthritis, which Dr. Lam and I are talking about, there are also a number of other indications, as you can see here, the non-radiographic axSpA, ankylosing spondylitis, as well as hidradenitis suppurativa. So it's been studied across different indications in different patient populations. And why that's important is that later on, when we were looking at the safety data, we now have the accumulation across these various patient populations, but also now we have the length of data in terms of following patients over a number of different years. And for psoriasis, for example, we present here 5-year data where we have no new safety signals with the PSO population. And you'll hear more from Dr. Lam about the data in PSA. So diving into Bimzelx and clinical outcomes, we are going to first take a look at the psoriasis data. So what we're looking at here is week 16 data, and we're looking at the outcome of PASI 90. So now PASI 90 is, as we know, a stringent outcome. So that's at least 90% improvement. We're looking at the proportion of patients that have achieved at least 90% improvement in their psoriasis activity compared to the baseline about 4 months later. And what you will notice are 2 things. Number one is that by week 16, there is a very high proportion of patients who achieve this. In fact, when you look across the different clinical trials, you'll see consistency here. Over 85% of the patients will have achieved PASI 90 by week 16, and that's important. And when we look at individually, looking at the different studies, whether it's against placebo or whether it's against an active comparator, such as ustekinumab or adalimumab, or against another IL-17, which is secukinumab, which is a IL-17A specific inhibitor. What we see here is the performance, the consistent, robust performance of Bimzelx. So when I tell my patients in terms of improvement in their psoriasis severity, these are the numbers that one can quote. So, and then first of all, but they will need to understand really the degree of improvement PASI 90 means. Patients will notice a substantial amount of improvement at PASI 90, and what we see across the clinical trials consistently is that we see about over 85% of the patients will achieve this stringent outcome. Now, one of the things that our patients may have is about how fast a medication may act. How fast after the first dose, Dr. Armstrong or Dr. Lam, will this medication work on my skin or my joint? And we have data for that in psoriasis and also in psoriatic arthritis. In psoriasis, what we see is that this very rapid response, such that after just the very first dose, the patients on average will, when you're looking at mean PASI as an outcome, what they will experience is that over 80% improvement in their mean PASI in the different clinical trials. And that's just after the first dose. And why that is important is that, especially in the skin where things are visible to them, that can instill a lot of confidence in the medication itself. And then in turn, I often think it instills confidence in us as clinicians and patients seeing that rapidity and that robust response that will also encourage them in terms of having to adhere to the medication longer term as well. Now, when we continue on with the data presentation here, what we'll see are looking at some of the high impact sites. And I'm also very excited to share with you later on about some of the pictures. One thing I wanted to, before we go into the high impact sites, is also show you the PASI 100 data. Now, when I think about degree of clearance, PASI 100 is really the holy grail in skin clearance, PASI 100 or IGA of 0. So either 100% improvement, PASI 100, or complete clearance, which can be measured by IGA 0 or very similarly PASI 100. And what we see is that by week 16, we have consistently about 60% of the patients across the different clinical trials achieving PASI 100 at week 16. And I still remember when this data was unveiled and the excitement, I think, from the community that we received when we saw this type of the data. And then I was a clinical investigator in the Bimzelx clinical trial as well. And I can tell, for example, in my clinical trial patients, when this is before approval, the degree of improvement really was extremely encouraging for them. But to be able to achieve 60% of PASI 100 at week 16 is really something that I think we're all very proud of as investigators and also I think as clinicians with experience with this medication for our patients, that they're able to achieve this level of response. Now, talking about high impact sites. So first of all, what are high impact sites? And this is a term I think in dermatology we've kind of grappled with different versions of it. First, it used to be called special sites or sensitive areas, and now we're talking about these high impact sites. And high impact sites means that these sites have a disproportionate impact when they're involved with psoriasis on patients' quality of life. Later on, I also recognize high impact sites. Sometimes when I talk to my patients, if I just use the jargon like that, they may think I'm talking about the palms and the soles where we tend to get impact there. But then I explain these are oftentimes involves the facial areas, genitals, palms and soles, axillary, intertriginous areas, because they have a disproportionate impact on patients' quality of life. And what we see is that in terms of those sites, more than 80% of the patients achieve complete clearance for those high impact sites. And on the left-hand side, we have 87% for the palmar plantar areas. And then for the scalp, we have 84% of these patients achieving complete clearance of scalp by week 16. Now, what about longer term data? I just showed you data that's at week 4 as well as week 16. And now let's take a look at long-term extension data. And then here is a brief review of the study design of the open label extension period. After the parent trials, the patients were offered the opportunity to continue in the open label extension period. And I'm going to show you some of the data from that particular period. So here we are looking at the US and Canadian population in the open label extension with psoriasis. You'll notice 2 lines. The first line represents that of PASI 90, and then the second line, which is the purple line, represents PASI 100. So first of all, we're talking about very high endpoints, very robust endpoints for our psoriasis patients. And when we're looking at PASI 90, what we see here is that the vast majority of the patients achieve PASI 90 at 1 year, so 96% of them. And then over time, when we're looking at up to 5-year data, the vast majority of them are able to maintain it. So at the end of 5-year period, we have nearly 90% of them maintaining PASI 90. And when we look at PASI 100 data, what we see is that by year 1, about 80% of them achieve PASI 100. And if you were to follow them over time, we see around the same number of patients, 77%, also maintain PASI 100 at 5 years. So what does that data mean to us when we counsel our patients is that if they respond to Bimzelx, the likelihood of them maintaining that response is extremely good over time. And that means fewer switches from Bimzelx to another medication, but also significant maintenance in their improvement in their quality of life. Now, we talked about high impact areas, and I promised you that I would show you some photos. So here they are. And what we see here are some real world examples. And in fact, you as someone with experience with Bimzelx can submit these photos to the Bimzelx Transformation Center, where we can have those catalogs. So these are photos from Florida, Coral Gables, patients from Coral Gables, Florida. And what you can see is that patients at baseline and then after the first dose of medication. So in this particular patient is 3 weeks later. So you can already see the significant improvement on their extremities, the dorsum of the hands, and also very impressively on the right-hand side, what you see is that is a substantial improvement in clearance, really, of the scalp lesions in this patient. Now, let me show you another example of a patient from the real world. This is a 52-year-old female, and this is looking at a high impact and difficult to treat area. So looking at palmar plantar disease and also in a patient with skin of color. And you will notice is that significant improvement at week 12 of the palmar lesions as well as the plantar lesions in this particular patient. So really showing the ability of Bimzelx in psoriasis and its phenotypes. And Dr. Lamb, so tell us more about PSA results.
Yeah, so first I have to say those pictures are really amazing. And as impressive as Bimzelx effect is in the skin, we also see similar effects in the joints as well. So I'm going to just fly through some of these slides. The pivotal trials in psoriatic arthritis were the Be Optimal study that looked in bio-naive patients and the Be Complete that looked at bio-experienced patients. Both were very simple designs. Subjects were randomized in a 1-to-2 fashion to either receive placebo or Bimzelx. The dose is different, 160 milligrams every 4 weeks. At week 16, the primary endpoint was an ACR 50 response rate, so a 50% improvement. And then those in placebo were allowed to cross over to Bimzelx, 160 milligrams every 4 weeks. And then there was an open label extension that went out to 104 weeks. So here's a primary endpoint in ACR 50, so a 50% improvement. And what we saw was that at week 16, a very significant percentage, so greater than 40%, achieved this response rate, which is considered to be very robust. This is a very bold primary endpoint. But more importantly, when you look at these kinetic response curve, where the x-axis is time in terms of weeks, the y-axis percentage of patients attaining the response, we see that the response was pretty quick. You know, we see this good upslope, and even by week 4, around 16 to 18% of subjects achieved an ACR 50. So for joints, that's actually considered to be very quick and very robust. This next slide shows longer-term data going out to 2 years, out to week 104. And then here are the three lines. The plots are, the top teal line is an ACR 20 response, so 20% response rate. The middle line before is the ACR 50, what we saw before. And the bottom, the darker line, is ACR 70, a 70% response rate. And kind of like what we saw in the skin, we see this durability of response, that the maintenance of response goes out to 2 years. We also see a relatively quick response, as demonstrated and reflected by the steep upslope within the first 8 weeks. Now, the durability or longevity response is really important, and this is one of the measures that's being emphasized in rheumatology, that when you start a medicine like Bimzelx, it will continue to work. Our group presented some abstracts a couple of years ago where we asked a very simple question to subjects with psoriatic arthritis. It wasn't very scientific, it was just, what's the most important factor to your care? But the responses really surprised us, and I think that's why it got a lot of airtime. And I thought patients would say the most important aspect of their care was how well a medicine worked or how safe it was. But it turns out the most important consideration was how long a medication lasted. And the patients said that every time a medicine was started, there was this angst, there was this uncertainty. Would the medicine work? Would they have side effects? Would they afford it? Would they have to take time off of work? And every time a medicine stopped working and another medicine was started, that whole cycle of angst and uncertainty recycled. So they wanted a medicine that you literally could set it and forget it. And we see that not only in the skin at 5 years, which Dr. Armstrong showed, but now in the joints at 2 years as well. And in fact, the data for Bimzelx in joints was so impressive that it caused them to look at the data in a different way. And that is looking to see if we can attain zero disease activity in each of these different domains, whether they're swollen joints, tendon joints, enthesitis, dactylitis, psoriasis, nail psoriasis. And you can see whether it's in the bio-naive subjects, which is the middle column, or the bio-experienced subjects, which is in the far right column. Bimzelx was able to get almost around 75% of subjects with complete resolution of swollen joints, about 40% of subjects with complete resolution of tender joints, almost 70% of subjects with complete resolution of enthesitis, over 90% with complete resolution of dactylitis, over 70% with complete resolution of skin psoriasis, around 80% with complete resolution of nail psoriasis. And keep in mind, a lot of these domains are very hard to attain, but from a rheumatologist's perspective, the one that really was the most impressive was that 89% of bio-naive subjects had absolutely no radiographic progression. That is, no occurrence of erosions or joint space narrowing at week 52. So what that means is that decreased joint destruction, hopefully that would mean preservation of quality of life and functioning. Now, these next few slides is just going to be looking at the kinetics response for some of these domains. And again, the kinetics that we see, whether it's swollen joints, whether it's enthesitis, or whether it's nail psoriasis resolution, we see a relatively quick onset, maintenance and durability of response at least out to 2 years. So that's actually really good. And actually, I've always been really impressed with resolution of nail psoriasis, because I always thought that for the symptoms to resolve, the nail would have to grow out. So we can expect the complete resolution at a year or 2 years. But I was really impressed at the week 16 data that around 35 to 47% of subjects achieve complete resolution of their nail psoriasis, at least as determined by the modified nail psoriasis severity index as early as week 16. But again, I think that just reflects how quickly and how potently Bimzelx works. So the question is, well, those are the individual domains, but what does it mean when you put them all together? And the two most dire complaints that patients have with psoriatic arthritis is pain and fatigue. Pain is pretty self-evident. Fatigue can be one of the most overwhelming symptoms that patients with psoriatic arthritis have. And in fact, it can be so overwhelming that most rheumatologists, myself used to be included, we would avoid asking patients about fatigue because they were so multifactorial, they go down rabbit holes. But now we have objective data that show that if you can get complete resolution of swollen joints, you get improvements in pain. In fact, the majority of patients, 55%, will report a greater than 50% improvement in their pain and improvements in fatigue. About 48% of patients will have a clinically significant improvement in their fatigue as measured by the FAAD fatigue scale. The minimal clinically important difference is an improvement in 4 points. So now I actually proactively ask patients about fatigue because we have objective data showing improvements in fatigue with medications like Bimzelx. Okay, so that was the clinical data. The other side of the coin is safety. So Dr. Armstrong, why don't you walk us through some of the safety in psoriasis, and then I'll follow up in psoriatic arthritis.
Absolutely. So let's take a look at the safety data here. And here we first look at the short-term safety data. And on the left-hand side, we see that of psoriasis. Overall, what you see is that during the week 16, the rates of adverse events were very similar between those treated with Bimzelx versus placebo. There were higher proportion of patients who experienced oral candidiasis, and later on I'll show you the long-term data for that as well. But overall, what we see is that a pretty reassuring safety profile with low rates of infections, and also it's very well tolerated among the psoriasis patient population.
Yeah, and same in psoriatic arthritis. The candidal infections and oral candidiasis does appear to be a real signal. Rheumatologists, we perseverate on safety. I guess going back to that old adage of first do no harm. And you can see that for all the other adverse events, especially those of special interest, the event rates were low, they're comparable to placebo. And you can see, at least on the bottom right, all these zeros. Zeros with regard to adjudicated major adverse cardiac events, adjudicated inflammatory bowel disease, suicidal ideation behavior, etc. Okay, but what about the longer term data?
Yeah, so let's go ahead and take a look at that. The long-term data here, we have, just go back one. Okay, so here we have the longer term data, and we're very fortunate to have up to 5-year data looking at this. And overall, what we see is that the short-term data we just reviewed is concordant with the long-term data. Overall, when you follow the patient population over time, you don't see an increase in the adverse event rates over time when it's exposure adjusted. At year 4 as well as year 5, when you look at the comparison as we go along the time horizon to a longer period of time, we don't see any increase in any of the safety signals. And also what we see is that for oral candidiasis, the rates are overall stable, if not decreased slightly over time.
Yeah, we see similar findings in psoriatic arthritis out to 5 years, that there are no new safety signals. However, one of the things that I want to concentrate on is suicidal ideation and behavior. You know, there are some concerns with other agents in the treatment for psoriasis, psoriatic arthritis of this signal. So during the Bimzelx clinical program, patients were proactively evaluated for suicidal ideation and behavior at each visit. And what we see is in the psoriasis arm, so that's the middle column, there was 1.8% of Bimzelx treated patients who had passive suicidal ideation compared to just 0.6 in placebo treated patients. That's a 3-time increase, so a relative risk of 3.0. This resulted in 3 suicide attempts out of 2,480. So that's an event rate of 0.4 per 100 patient years. 2 of them had a history of prior suicide attempts. And this resulted in 1 completed suicide out of 2,480 subjects for an event rate of 0.1 per 100 patient years. And that one suicide, completed suicide, the patient did not have a reported psychiatric history. Now in psoriatic arthritis, the data is a little bit different, for that the rate of passive suicidal ideation was just 0.3% in the Bimzelx treated patients, as opposed to 0.7 in placebo treated patients. So it was actually lower. This led to one suicide attempt for an event rate of 0.4 per 100, and that occurred in a subject who had pre-existing psychiatric conditions, but it led to 0 completed suicides. So that definitely does need to be kept on your radar, but I think the greater question is context. So Dr. Armstrong, kind of walk us through the context of this data of suicidal ideation behavior.
Yes, yeah. So I think, first of all, that's a really nice review. And I think understanding context is really key to understanding the data. First of all, it's important to know that in the Bimzelx clinical trials, when we're looking at whether it's psoriasis or psoriatic arthritis, these patients were screened for suicidal ideation and suicidal behavior more frequently than any other prior psoriasis studies. So this is very important to note. And then in addition to that, what we also are able to provide here is how does Bimzelx data, how does that look in the context of other biologics that we know here? So what you see here is that on the left-hand side, you see the event rates for Bimzelx, for example, and that's 0.13 per 100 patient years. And this here represents the suicidal ideation and behavior overall. When you look at the red bar, that's the anti-IL-17A, what you see is that where Bimzelx is, it's within the rates of what we would expect with anti-IL-17A agents. And specifically, we're talking about the data for secukinumab as well as ixekizumab here, that's grouped together as anti-IL-17A. And then if we go over one more, we're looking at IL-17 receptor inhibitor here, which, as you can see here, in its pivotal studies has shown a rate of 0.49. So overall, whether it's comparing it with the existing other IL-17A, where Bimzelx shown either similar or numerically lower rates, or with IL-23 inhibitors, it's also within the range of reported suicidal ideation and behavior, or benchmarking that against overall the moderate to severe psoriasis patient population overall, the rates of suicidal ideation and behavior are within the ranges of what we see with the other biologics, as well as the background psoriasis, moderate to severe psoriasis population. And then we're going to continue on and to take a look at, in addition, talk about some of the ALT and AST elevations. There were some patients where this was observed. Overall, the rates were low and did not lead to discontinuation of Bimzelx in the clinical trials. And speaking of context, the important context is that for many of the studies, it had an active control arm with another biologic. And as you can see here, the Bimzelx in context with other biologics that were studied, whether it's adalimumab, secukinumab, or ustekinumab, the rates were overall either the same or numerically lower in terms of the AST and ALT elevations with the other known existing biologics. And then finally, oral candidiasis. So it's interesting is that in the clinical trials, the rates of oral candidiasis were lower in the psoriatic arthritis trials when we were looking at those numbers, absolute numbers in reference to the psoriasis numbers. But it's very, very important to note that when we do see them, over 90%, 95% of them were mild to moderate. And when you're looking at the entire population, only about 0.7% of the patients discontinue Bimzelx due to oral candidiasis. And this is important to know. And when I counsel my patients and I convey to them that a small proportion of patients may develop oral thrush or oral candidiasis, and if that's the case, the vast majority of patients do not need to discontinue Bimzelx, and we can treat you with an antifungal medication, and then that can be initiated concurrently with ongoing Bimzelx, and typically the oral candidiasis resolves without any complications.
So we already went over most of the important safety information, but just a couple of things. Number one, evaluate patients for tuberculosis prior to starting Bimzelx. Treat them if they have latent TB prior to starting Bimzelx. If they have a history of latent tuberculosis, that should definitely be on your radar screen. Liver enzymes should be tested before starting Bimzelx and periodically throughout. In cases of inflammatory bowel disease have been reported with IL-17 inhibitors, including Bimzelx. If a patient develops signs and symptoms, obviously that should be further evaluated, and then update all immunizations prior to starting medications. The most common side effects include upper respiratory tract infections, oral candidiasis as mentioned, headaches, injection site reactions, tinea, gastroenteritis, herpes simplex infections, acne, folliculitis, other candida infections, fatigue, diarrhea, and urinary tract infections. And then Bimzelx comes in two very convenient device options, either a prefilled syringe or an autoinjector, and it comes already prefilled at the appropriate doses, either 160 milligrams or 320 milligrams. The volumes are commensurate, so 1 milligram or 2 milligrams, depending on the 160 or 220 dose. But this really allows the patient to be met at his or her point of convenience or their preference. It really allows great flexibility. Now, in rheumatology, the dosing is very simple. It's 160 milligrams every 4 weeks, but I can never keep the dosing straight in all of the dermatology indications. So, Dr. Armstrong, I'm going to ask you to go over the dosings and the different dosages in the dermatology indications.
Absolutely. So with dermatology, we have typically induction period. And so for psoriasis, for example, for the first 16 weeks, we have this 320 milligrams every 4 weeks dosing. And then after the first 16 weeks or after the first 4 months, that in psoriasis, it goes to 320 milligrams every 8 weeks. So for the vast majority of our patients, the maintenance dose is every 8 weeks. However, for patients that are heavier, that's weighing more than 120 kilograms, you can actually maintain them on Q4 week dosing for psoriasis. Now, if the patient has both psoriatic arthritis as well as moderate to severe psoriasis, then the dosing will go with the greater psoriasis dosing in those cases. And for HS, think about HS is double the frequency as psoriasis. So during the induction period, you are giving 320 milligrams every 2 weeks in HS. And during the maintenance period, everyone gets 320 milligrams every 4 weeks. And then as Dr. Lam and I have reviewed here, one of the key advantages that we also want to highlight is really the accessibility of Bimzelx. I know in terms of psoriasis coverage for our commercially insured patients, now we have 90% of commercially covered patients are able to obtain Bimzelx. And for those, if you do have a commercially insured patients, you can also be connected with a Bimzelx and Navigate Bridge in order to have access to Bimzelx. So as you can see, it's a CVS Caremark exclusive and also ESI single step edit. And really, I think it gives us the confidence of being able to obtain Bimzelx for our patients when we deem the patient to be appropriate. And then finally, as we're thanking you for the evening here, I think some of the key takeaway is that we saw in skin, for example, we saw the rapid response in terms of getting patients to complete clearance, even just many patients being able to achieve that after 4 weeks and greater than 60% after 16 weeks, and that being able to maintain that level of high response over time. We also talked about safety data up to 5 years in the psoriasis clinical trials. And I'll have Dr. Lam kind of close up on some of the key takeaways for psoriatic arthritis.
Yeah, so I began the talk by saying that in rheumatology, psoriatic arthritis is one of the more complex heterogeneous diseases. That used to translate to being one of the more frustrating diseases to treat. But now, because we have such great medications like Bimzelx, it becomes one of the most gratifying and satisfying diseases to treat because we can really make a difference, whether it's PASI 90 or 100, complete resolution of skin, whether it's improvements in their joints and the long-term maintenance. And then when you couple that to the safety, the stable safety data that Bimzelx has shown, and the accessibility and convenience that UCB has really put thought into. It really makes a complete package. You know, when I was in training, I was taught to always try to find the right medication for the right patient at the right time. And my biggest frustration is once we get to that point to not be able to do so because of access or convenience issues. I think this really represents a very thoughtful approach to really consider Bimzelx for patients with a variety of either new or unresolved skin and joint symptoms. So with that, I want to thank you guys all for your time and for your attention, and we'll be happy to answer any questions. And actually, Dr. Armstrong, let me just say it's been a pleasure presenting with you again. It's always such an honor.
It's an honor is mine, and I want to thank everyone for your attention.
Thank you, Dr. Lam. Thank you, Dr. Armstrong. Unfortunately, we even passed over the head of the clock here. It's 8:01, so we won't be able to do the questions, but I do want to thank both of you guys. It was great. I really think it's very important for us in derm to hear the perspective from rheumatology, because we always struggle when it comes to joints. So it was great. I really thank you, Dr. Lam. Of course, I thank you, April, as well, but it's nice to hear a different perspective. And I'd like to thank our supporter, UCB, and I'd like to thank everyone who attended tonight, and have a good night and good evening. We'll see you our next program.
Bye-bye. Thank you.
Bye, everybody.